Dr. Suria, Pantai Laguna Merbok on blood.
Okay. Dr. Suria, I suppose the first question I'd like to ask is, why do we have different blood groups?
Okay. All right. Let me start first. I mean, it's good that you start off that we have different blood groups. So that's very good enough that we already aware that we have different blood groups. So before I start why we do have a different blood group, we should know at least a little bit what are the blood groups available. So it's big detail. If you go in, there are many types of groups that we can take major grouping and minor grouping. But what we are usually do here is a major grouping. We call it ABO group system. Okay, right. Plus a rhesus group system. So by that we know that we have a blood group A, B, O, AB with a rhesus positive or negative. So it can be A positive, A negative, B positive, B negative, O positive, O negative, AB positive or AB negative.
Right.
So this is a major blood group that we actually cross-matching before we transfuse. So good question, why we do have different blood groups and why we should have that. So we know that actually it is a part of evolutionary process and it is a unique to the particular persons. So we know it is a change in amino acids or call it sugars on the surface of your blood. So it is inherited, you get it from your parents. So you will have unique blood by combination by both parents' blood based on it. So that's how it works. Okay. Why we do have different blood groups? It is because of it inherited from our parents. So these are major groups. So it is a genetic. It's the same as like why we are differ from one from another in terms of color, our height, our look and all this because it's the inheritance. Mm-hmm. So to be say functions are same. There is no difference between functions groups A to B differ. They are do the same functions. There is nothing is to be say superior to the another one. They are the same. It's just the grouping are different. The groupings are different.
Have there always been this many blood groups? Or, I mean, I'm just trying to sort of think, you talk about when did it start? Yeah. Because you're saying it's a combination between mom and dad. So like going all the way back, was there one blood group? Or were there always different blood groups?
It starts as soon as you are in mother's womb because it is carried in your genetic package. So when the baby formed itself, it already have is the unique blood group. And you know that blood group of yours may be not the same as mother. So that's why we have a placenta, it's being separated. So the mother's blood group and the fetus blood groups are not mixed. So it is a combination of both mother and the father. So if let's say the father is A groups, the mother is a B groups. So you have a chances of getting a baby A, B or AB. So each are carrying 25. So impossible to have a O positive because both mother is A and B. Okay, so that's how it goes.
Yeah. All right.
So like back with our ancestors though, I mean, did we just have these established main groups with our ancestors? Yeah. I'm going back like, I don't know, 3 million years ago. I mean, do we have the, I'm just trying to understand the idea of different blood groups and where they came from, not just sort of from our parents, but way back.
It is actually, you see, the groupings, actually it is a part of technology, science evolutions we got to know. Obviously, the transfusion itself started a few years back, 100 years back, our transfusion. So we do notice last time, those days when we transfuse, are there the patients develop allergic reactions? They reject the blood that we transfuse. So that makes us to think why one person's blood can't be transfused to another person's. So that makes people to go into research and find out what actually that the body why rejecting. So actually because you must understand blood actually a protein. So when we transfuse A person's blood to B person, it has to be compatible as much as possible. It cannot be 100% compatible. So we are trying to cross match it so that it is most compatible blood to that person. Okay, so yeah.
No, I was just gonna say, okay, so can you walk us through, because you're touching on this now, but can you walk us through in which way they're different to one another then?
Okay, for instance, when we are going to transfuse a person, a blood group of A positive, we need to find a donor with A positive or O positive. We can't transfuse B positive blood to A positive patients, recipients. So what will happen there? But when we're talking about A positive, your blood has A antigens in your cells. You don't have a B antigen. So the body will have an antibody towards a B antigen. It doesn't have antibody towards A because you're the A antigen. So when I transfuse B positive blood to your body, that disappears. The antibody that the recipient has, a B antibodies, will attract the cells, which is for them is a foreign body. So that where the reaction can start and can be fatal. So that's what we are trying to do. That we try to get what we call compatible blood.
Is there a baby crying?
There's a baby screaming in the background, Doc.
Like it's outside the clinic.
Right,
so
right,
we are
okay.
the clinic.
I'm like, wow, how scary!
we take it as a blessing.
Right, how
Early morning,
scary is our chat on blood that the kid
No,
is
yeah,
crying.
we're talking about blood and stuff, and you can hear kids
No,
screaming.
no.
So I think we better just.
Nobody withdrawing a blood. It's
Right.
outside. It's done already.
No, I understand, but
Before
it's just
going to clinic as
on.
usual.
Yeah, no, I'm just saying that on audio, on radio, though,
I
we're
understand.
talking about blood,
Yeah.
and then there's a child screaming. So
Yeah.
it's just.
I'm just
Extremely sorry.
no worries. I'm just trying to understand it. So basically, in a strange way, I'm not saying it's exactly like it. Blood is like water, but then A antigen, we can look at it upon like there's some syrup in it. But then the B antigen is like orange. You cannot transfuse orange into someone with syrup blood in a way, right? So,
Something like that.
yeah.
You shouldn't
can't
mix
mix it.
it. Yeah,
Yeah.
correct. You're right.
Right.
There'll be a rejection process will happen later.
Okay.
Yeah.
Now, humans we're mammals, right? Do animals have the same blood? And all mammals have the same kind of blood that we do?
You see, yeah, we are grouping them as well, A, B, O, and research, because that is actually organ donations. You can check it in some country. We do take part of animals' organs to be transfused. So we have to check the ABO grouping too. All of the cross-checking or pre-check is actually ABO grouping.
Right.
Yes. Okay. So, if, for example, instance, you are doing kidney donations, donor and recipient also must have a compatibility in a blood grouping as well. Apart, there are a lot of others, but on a week is blood grouping too. They have to be matched.
So organ donors have to be cross-matched the same way blood donors have to
exactly.
be cross-matched.
Exactly.
Because it has blood in it. Is that what you're
Yeah.
saying?
Exactly.
Right.
It has the antigen antibody. Actually, it's been the exposed. You can reject the organ.
All right.
So it's one of the
remember,
composite.
still syrup and orange juice. It's the
Yeah.
cordial that's actually in the drink that makes the difference. It's all just water, though, basically.
Right. Okay.
Right. Yeah. Correct. Something like that. Yeah.
So, Doc, you're talking about basically the discovery of these different blood groups. How long ago when transfusion started? Was it a couple of hundred years ago? When did the first transfusion start?
It is being mentioned that the blood type A is actually one of the most ancient, and it is existed before human species evolved from its hominid ancestor. So it is being thought like 3.5 million, roughly.
Okay. Right.
Yeah. So the blood grouping is not only belongs to us. I think the animals do as its own. ABO grouping too. So it exists many 3.5 million roughly. That's the calculation. And it was told that A is one of the pioneers, then followed by B.
Right.
Yeah.
So the discovery, I go back to what I was asking, the discovery of the different blood groups came as a result of transfusion. Some worked, some didn't, and the doctors were trying to investigate and figure out why it worked with some patients and why some patients had a severe reaction. And that's where they discovered the different blood groups. Is that correct?
Correct.
And they then discovered that it came as a series of evolutionary steps, that we had these different blood groups from blood type A. So are there possibly new blood groupings that we haven't discovered yet, or are yet to evolve because of evolution?
I wouldn't be surprised.
Really?
Yeah, but the thing is, as far as we establish specialty, transfusion itself has specialty. We got a transfusion specialist. So we have go to the advanced and we got a blood transfusion specialist. Okay, so as far as we know, we have done the best. I mean, we already advanced and we already, discover as much as possible. So they are obviously the new updates are coming. But what has been here, it's fact and it is established. Yeah.
Okay. Doc, when I was doing a bit of research for this, I came across a couple of very interesting names. So, you were mentioning A, B, O, AB, which is positive and negative.
Correct.
But some blood types have names like Bombay phenotype and golden blood. What's so special about those?
Okay, come. So you see, this is actually it's like an exam questions. Why? Okay,
Yeah,
this is a special. Okay, let me answer it. What is Bombay? Okay, you understand. Bombay is in India. This is how it has been discovered. Okay, so it is discovered in 1952. It has been Bombay blood group is very unique in sense that each red cell, the one that I'm telling about, it doesn't have any antigen on it, A, B, or O, because they don't have a gene deficient in expressing gene called H gene. You need to have this H gene in order you to produce A or B antigen. So when you have a deficiency of these H gene expressions, you're not able to produce any antigens. So basically, we do confuse Bombay blood group with O, because O don't have A or B.
Yep.
Even Bombay blood group don't have A or B.
Right.
So how to differentiate these two? This is where the discovery comes, because when we thought is O, when we transfuse O group, they develop reactions, because O group will have antibody towards A and B.
Right.
Alright, so they start to have reactions. So that's how we got to know, oh, this is something different. So they started to investigate and find out that, oh, this is something different. So the only way to differentiate between O and Bombay group is by doing H genetic testing. So H antigen is not absent in a Bombay group. Meanwhile, in O group, they have a H antigen.
So is that a disorder then?
It is not really a disorder. It is like, as usual, that we have an A group, they have Bombay group. It is not a disorder anyway.
Okay.
But it is not, the good thing about it, it is not as prevalent compared to Malaysia, compared to not part of it. And it's very rare. It's like I can't exactly tell you the figure, but it's a very rare group. But if you have a family history, genetically that your parents or grandparents are Bombay blood groups, so there is chances of so you need to be screened properly before we transfuse.
So that means though, if I'm from the Bombay blood group and I need someone to donate blood to me, that means someone needs to be from the Bombay blood group to donate to me as well.
Exactly.
Wow, consider how rare it is.
Wow.
You are very unique. So you're very unique there. But anyway, in Malaysia we don't record such cases. Anyway, we don't have. So we are mainly follow the ABO grouping.
Yeah, but
so
what's the other one again?
Golden blood. So what's golden blood? Is that another rare type of blood type as well?
Oh, they have a lot of names and telling golden bloods, like you are the unique one, like the Bombay blood group, you are the unique, golden bloods. So such a goes like, for example, AB groups is considered that very needed. They are universal acceptance. O is a universal donor. They can donate to everyone, but you only can accept from your own group. So I, as an O positive, I can donate to anyone. I'm a universal donor, but I only can accept from my own partner O. I can't accept from A or B. So
okay,
yeah.
O can give to everybody. O can give to everybody, but cannot receive from anyone but itself.
That's the irony of it.
Right, and so with these special ones like the Bombay phenotype and golden blood, they can only receive from their own type, not even universal O.
They are just given to their own kind, and they can receive from their own.
Wow.
Yeah, I heard, I don't know if this is true or not, but reading up about the golden blood one, there's only 9 individuals in the whole world.
This is what we call it very rare kind of things. So this is what we don't generally include in general screening. So that's why we still hold to our major blood grouping, ABO, and research grouping. Yeah.
Okay, so
wow. Okay, I'm just blown away.
yeah.
But this is an overflow of information. Sometimes it is. That's why we try to make it very simple. That we are grouping and because this is beyond, because it's very rare. Common is more common. Commonest things has to be more common. So we don't.
Right.
It's always interesting to know, though. So Doctor, if the blood groups happened due to mutations, you were saying that the first original blood group was what? Was it A?
A, I think, right?
Yeah.
Right.
A, B, and A.
How and why did they evolve?
See, evaluation is basically to adapt to the environment, our current environment, and our change in our body, height, our skin, eyes, vision, all is evolution process to make adapt to the environment. So I guess, the blood group evolution is also a part of evolutionary theory, and it's a part of to adapt to the environment. There are a lot of assumptions, a lot of some kind of not verified research. They're telling like O group more prone to get mosquito bites. You can easily get AIDS, malaria, things like that. Yeah, but they call it tastier to the mosquitoes, right? Your blood. But how true it is?
Doc, hold on a second. Just have to. We'll just pick that back up again from.
Like dengue, from dengue.
Dengue, yeah.
Okay. So how far it's true, we know, because as far as I know, when we have a dengue patient admitted, we don't check the blood group.
Right.
We don't.
So no one's actually done a study on this specifically.
Some has done.
Like, that means if I have O, I'm very yummy to mosquitoes, is it?
Yeah, actually, the study moved towards malaria.
Right.
Malaria mosquito. Yeah, they were telling that when you have O positive, the malaria antigen are more stickier to because it don't have your blood cell don't have any antigen on top, so it can more easily penetrate, and you can have more severe, easily transmissible diseases compared to the A or B group. But how true it is, because you see, when we admitted a patient with malaria or dengue, we don't go and check the blood group to verify, and the treatment does. So the thing is, severity doesn't differ between A or B O. So yeah.
Right, I see.
I wanted to ask you something interesting that you just said. So it seems to me that what your blood type is quite important, a piece of information, right? Yeah. If a patient comes into the hospital, like with dengue or whatever, you said that you don't actually check for their blood type. But obviously they'll be checking your bloods for things like dengue levels and stuff. So why is checking for a patient's blood type not, part and parcel of what you do automatically? It is
not a mandatory. It is not going to affect your management unless the patient requires blood transfusion. We need to test, or the patient requests for it. So you see, any lab test that we are doing, it's time consuming and cost. So it has to be justified with your clinical indications. So checking blood routinely, it is not part of routine blood investigations, unless the patient requires any transfusions or the patient requests us that I would like to know my blood test. So you want to know your blood type, it is actually called medical checkup. That's how our patient basis we can do that.
Right.
How long does it take for the lab to process?
It is, I think, less than half an hour you can know. It is just a compatibility test. You can do it very fast.
It seems interesting that it's not like a mandatory thing, like to say.
You all know your blood group or not? Asha and JD, you know your blood group?
I know mine. I'm O positive.
That's great. Same like me. Asha, how's your blood group?
I'm A something. I'm A something.
Okay.
Actually, it's hard. I used to carry a card.
Yeah.
It's in my wallet.
Yeah. No.
I don't know my son's. Yeah.
Why I'm asking this is quite crucial to all of us to know our blood group.
Why? Why is it important to know your blood type?
You see, knowing blood group is to prevent the risk of you receiving an incompatible blood type at time of need. So when there is an emergency, when I lost a lot of bloods, we don't have a time for a full cross matching. So at that time, we might go a saline matching, we call it, very fast. So what we check only is ABO grouping. It will be very helpful if you carry a card, or the patient can tell us what group you are. Obviously, we double check with that laboratory, but it will be very good that you know. And secondly, at least you can be a blood donor. Normally, blood donors, they know what group they are. So when you know your blood group, it's easier for us. Like say, you can be a rare one, A negative.
It's so you can be. Are all the negatives very rare?
Exactly. O negative is the most rare thing. So generally when we talk negative groups, rhesus negative groups are a bit rare, so they are most wanted. So if you know your blood group and you're negative, you can be excellent. You can always give your blood to your relations who are negative group too. So that's in emergency they ask you, Asha, what blood group you are? We need A negative. I know I'm A something. I don't know. that's where the knowing your blood group is very crucial.
So anyone can give blood?
Definitely. Anyone can give blood after you pass your screening test.
Okay, so what do you need to do in order to be a blood donor?
Okay, the screening tests sort of been updated. As far as I know, you need to have enough your body weight, 45. Your BMI must be okay. You need to be healthy candidate. Okay, you shouldn't have carried any viruses. That thing will be checked, like especially HIV, hepatitis B, C, and all this, VDR, and all this has been checked. And yourself not taking any like diabetic hypertension medicines, something like that. You don't carry other viruses in the body basically, and you're not alcoholic. Okay, you couldn't take alcohol and go and donate the blood. Okay, so
what happens? Let's just say,
what happens if you have a glass of wine and then you go and donate blood the next day?
What happened? When alcohol metabolized, it has some metabolic, we call it. It can be very harm, and when we transfuse, you see, to another person with non-alcoholic, that metabolic can cause more danger and can cause slice of his own cells. So that's why we don't advise.
So how do the people taking our blood check for stuff like this though?
This is what your declarations.
Right. So it's up to you. You might not declare that you have.
They do screenings anyway, but to check whether you have high level alcohol, all these, we can know by laboratory tests and all these. But basically, we do declarations that you are carried your HIV, hepatitis B, C. All these, after you declare, you sign, we take your blood into the lab, and they will process it, and all the tests has been carried out. They verify it is clean and safe to be transfused. So it takes time. Yeah.
Right. So no matter what you declare, basically they don't check the blood.
No. We that's very dangerous. Some do declare and they don't aware that they have.
Correct. Yeah.
Exactly. Yeah.
We do check. We do double check the thing that you are doing. Some are doing a very expensive DNA test, netting testing for hepatitis C. Yeah. Because at the window period we can miss it out. So after do check everything and we certify this blood is safe. So you wait for the blood.
One more, Doc. I don't know whether it's true or not. It's an urban legend I've heard before.
Okay.
I think it was Cristiano Ronaldo actually said it, that he doesn't have any tattoos on his body because he wants to be a blood donor. Does that affect anything?
Yeah. Tattoo is as a risk of carrying hepatitis B because you might share the same needle and you're tattooing. But now I think expensive and kind of very advanced tattoo. I think they have disposable, single-use needle, so that shouldn't carry anything. But anyway, when we as healthcare workers we see someone with a tattoo, full body is full covered tattoo, try to come and give blood.
Yeah.
It is always in your screening form. Yeah, they do ask, "Are you have tattoos anywhere in your body?" So when you tick yes, you still can choose. But they will do a proper testing again, go through a test. But there is subject to rejection too. If the healthcare worker there say that for a tattoo they're very suspicious, we might reject it also.
Okay.
Right.
Do Malaysian blood banks need a lot of blood, or are they quite healthy in terms of?
Yes, we do need. You see, always there's a shortage of blood. Blood is actually we can't produce blood. We can't manufacture the blood. It has to come from a donor. And as we know, when we donate blood, we think that it's just a red packed cell that is going, but the blood can be processed to a variety of products. So not everyone require the red packed cell. It can be divided to platelet. It can go to the Cryo Precipitate. It can go to the FFP and whole blood. So there are indications which patients need which type of blood. So see, one pack of blood can be processed to many varieties. So that's why we need many donors so that we have enough stocks.
Okay, I was just about to ask you what parts of the blood are used for transfusions, and you've just named 4 or
Few.
5 different. Can you just break those down for us, the different components or parts of the blood that's actually used in transfusions and what they're used for?
Okay. The first of all is a whole blood. Whole blood is basically what you want it. The whole thing is
It's
contained
what Dracula
everything.
likes.
Something like that. It has everything inside. Okay, it has everything. So when we do transfuse, this is the most commonly when you lost more than 25% of the blood is lost. Let's say for an accident. So we can transfuse the whole blood. Or when we do a neonatal exchange, when baby born and the baby has some form of funny antibody that in your body, we need to exchange the blood. So we have to exchange the whole blood. So that's the indication generally. So second is your red cells. Red cells is the commonest blood product that we transfuse. It's a concentrated red cells. So normally we call it anemia. A patient will come with a low hemoglobin. So in this type of patients, we transfuse them a red cell, PEG cell, because 1 pint PEG cell can increase about 1 gram of your hemoglobin compared to I give a whole blood. When I give whole blood, it contains more than just PEG cell. It contains everything. So we are just concentrate what we were aiming for to treat. So that's how it is red cells given, and its half-life is about 42 days. 42 days after we process it. So we can keep it for 42 days. So for whole blood, is normally we keep for 35 days around that.
Oh, there is an expiry. Okay.
Yes, we do. When you transfuse blood, apart from checking compatibility, and I'll check the blood cells expiry date. We can't give the expired blood.
It needs to be oxygenated. Is that what it is?
No, it is stored and is on fridge.
Right.
So once you take it out of fridge in a box, it has to be transfused. You can't return it back to the blood bank.
Okay.
It is out of the cold chain, broken. So that's a possibility of contamination. Blood is an interesting menu for bacteria. Okay, all right. So then another type is platelet, commonest. It is always people call it yellow blood. It is yellow straw color.
Yes.
So it is actually a content of thrombocytes. It is given to people with a low platelet count. So we give this. Okay.
What would cause someone to have a low platelet count?
It has a variety of it.
Really?
Autoimmune, they have a lot of possibilities like autoimmune diseases, own antibody attack,
like
cancer
dengue?
patient. Dengue, okay. Very controversial. We don't transfuse platelet in a patient with dengue unless they go bleeding, because transfusing platelet in a low dengue patient can cause the outcome to be more poor. Okay, it will cover itself. Because you must understand platelet function not by numbers, it functions by the quality. We need both quantity and quality. You can have a lower numbers, but the quality can be excellent. So the function of platelet is to make your blood be clotted. So you don't easily bleed.
Did you say clotted?
To make your blood clot. When you have an injury,
You need to have clot.
you need to have these clotting things. The platelet will go and attach and cause the wound to be
Closed. Yeah.
stopped. It's closed, something like that. Okay, so that's a function of the platelet.
Platelet actually, Doc, if you don't mind me asking, platelets do a lot of not plastic surgery those what's a nicer word to say?
They will do plasma derived products.
Correct.
And all
Yeah.
that.
So they'll take the platelet, or if I'm not mistaken, I think so, and then they'll inject it into like the scalp and everything to help the hair grow and stuff like this, right?
Yeah, it is more to aesthetic medicines, and they have their own kind of.
Does it work? Does it work?
I can't comment on that. It is actually their field of interest, but it's been extensively studied. That all this.
Well, my
the
hair
other one is
a grown bag slightly, so I don't know. It seems to have worked.
You covered.
Yeah.
Then the other one is the plasma. Plasma, not also something like platelet, but it's frozen, so it can be kept for 1 year. It is once you take it out, then we have to use it back. And the other one that's quite important is a Cryo Precipitate. We call it precipitate. It is also frozen, and it is white in color, and we can keep up to 1 year. It is rich in clotting factors.
What does it do?
What is the
given on Cryo Precipitate? It is been given to the patient who need a clotting factor. We have 12 clotting factors. So mainly we give for those that deficient of clotting factor 7 and 8. So Cryo Precipitate. When we have bleedings, especially for example, after delivery, the woman go into the extensive, massive bleeding because they lost their clotting factor. This is where you need to give a cryo precipitate.
Because they cannot clot. I see. Okay.
Is this something that hemophiliacs would have then?
Yes, you're right. It's something like hemophilia when they don't have enough. But when now hemophilia, we are going to AB and we have a specific clotting factor and the factor that we're giving. Cryo precipitate contain all the clotting factors. While in a hemophilia, A and B, like A division of clotting factors 7, so we give only 7 supplements.
Right.
Okay.
Man, it's very, very specific. There's more to it than just blood. There's a lot of things within blood.
Exactly. We do process your blood and
amazing.
We make it.
So I've always wondered, do people make mistakes in transfusing blood from, let's say, someone in battlefield or something like that, and medics have to urgently pass blood from one person to the other? What happens if you put in the wrong kind of blood?
It has to be a major mistake. We call it transfusion error. Okay, and there is most of the time the near error happens. Okay, but they can have many checkpoints from the A until to B until it touches the patient. You need to go through the protocol properly to check everything, so you can reduce this error. It is very rare, and our KPI in any hospital, you should have a 0 transfusion error and possible 0 near miss anyway. So it can happen. If you transfuse wrong blood to a patient, you can develop reaction. We call it acute reaction or late reactions. But normally, when there is incompatible blood goes in with a few ml, it's as little as 10 cc of blood, can cause fatal.
Really?
So, yes, yeah. So because the reaction can be overwhelming. Okay.
What actually happens in that reaction? What's happening?
Your body will start react that some foreign protein has been entered, and your body will start release all form of cytokines and all the allergic hormones. Everything comes out. It can attack your own body. And in the end, the patient can go into breathing difficulty. The heart rate can go fast, and so on. BP can drop, crash. We call it anaphylactic shock. So that's the reason why we have to be very careful when transfusing blood. But there is actually even compatible blood. You can have small minor kind of complications, like you might have itchiness, a bit of rashes comes. So in the medication can go off. It's not a thing. That's why I'm telling, transfusing blood, it is not something like we're giving a fluid. It has to be very carefully judged who is supposed to receive, who not to receive, what are the indications. We need to go through a proper checking, counseling, consent, a lot of things. It's not easy. But when times come when needed to be given, we have to give blood, and we have to carry on. Yeah, we have to take care of this.
Doc, aside from emergency situations that require blood transfusions, any kind of emergency, in Malaysia, what kind of illnesses or diseases do we have here, or the most common ones that we have that require transfusions, that are very blood-centric focused in terms of treatment?
Yeah. We in Malaysia well known for thalassemia. I am sure that you all have got major thalassemia. So these people require blood almost every monthly transfusions.
Can you explain?
They can't produce. They are this genetic disorder where they can't produce their own fat cells. Okay, the deficient is the thing. So they are dependent on the transfusion. So it's called transfusion dependent thalassemia. Okay, and they thalassemia. So one of it is thalassemia. The others are actually anemia due to the iron deficiencies. They have a very lacking of iron. Then number 3 is maybe they have some bleeding disorders. They can bleed bleeding from the stomach and their colon. Cancer patients, leukemia patients. So all these that we actually regularly transfuse them, and we think that they need to get transfused. There are many other indications. And the other thing is kidney patients who are going for dialysis. So they also not able to produce certain hormone, we call it erythropoietin from the kidney, not able to produce anymore. So these erythropoietin required for blood productions. So these type of patients also require on and off blood transfusions. So these are the commonest things that we are doing.
And if you were to know, Doc, how far away are we in terms of science in creating synthetic fake blood that's workable?
Are they working on it?
I don't think so, because as I told you see, it's very complicated. But the blood actually is carried our own protein and we're giving to another person, it has to be compatible in many ways. So I don't think so at the moment there is anything that going on and approved that synthetic blood to be transfused.